In patients diagnosed with atrial fibrillation, roughly 1/4 of all ischemic strokes originate from a single anatomical pocket. During an atrial fibrillation episode, the heart's upper chambers lose their coordinated rhythm. Blood pools and stagnates inside this pocket, the left atrial appendage. That stasis promotes the formation of a microthrombus, which can travel through the circulation to the brain. For decades, the standard protocol to mitigate this cardioembolic risk has been oral anticoagulation, or OAC. While anticoagulants successfully reduce the risk of stroke by 2/3, they rely entirely on chemical prophylaxis. They require strict patient adherence and carry an inherent risk of systemic hemorrhage. The left atrial appendage occlusion study, or LAAOS III, tested whether physically sealing off the appendage during cardiac surgery provides additive protection against stroke, rather than acting as a replacement for blood thinners. The investigators wanted to determine if a one-time structural intervention could permanently work alongside ongoing pharmacological care. This chart details the baseline population of the trial, which involved 4,770 participants across 105 clinical centers globally. These participants were already scheduled for cardiac surgery for other indications. They were randomly assigned in a 1-to-1 ratio. Half would undergo surgical occlusion of the left atrial appendage, and half would not. This was a high-risk cohort. The mean CHA2-DS2 VASC score for predicting stroke risk was 4.2. Crucially, both groups were expected to receive standard stroke prevention therapies. Roughly 80% of patients in both arms continued oral anticoagulation regimens during follow-up. The occlusion itself was performed using established surgical techniques, predominantly complete amputation and closure, or stapler closure. By testing the procedure against an active, medically optimized control group, LAAOS III isolated the specific mechanical value of removing the appendage. The trial's primary outcome was the first occurrence of an ischemic stroke or a systemic embolism. Over a mean follow-up of nearly 4 years, participants who received the occlusion experienced a 33% relative reduction in that primary outcome. This table displays the trial outcomes. The primary endpoint resulted in a hazard ratio of 0.67, with a significant p-value of 0.001. This Kaplan-Meier survival curve shows the cumulative incidence of stroke or systemic embolism over time. The distance between these two lines represents the efficacy of the intervention. But examining the start of the data reveals a specific temporal dynamic. In the first 30 days following surgery, the incidence rates for both groups are nearly identical. This delayed separation in the curves suggests that the underlying causes of stroke may differ between the immediate postoperative phase and the long-term follow-up. We can analyze this shift by dividing the data at the 30-day mark. In those first 30 days, the hazard ratio was 0.82, showing no clear statistical benefit from the occlusion. Early strokes are frequently driven by the surgery itself, factors like aortic manipulation or bypass mechanics. Because these are procedural emboli, physically sealing the appendage offers no immediate protection against them. However, beyond the 30-day window, the lines begin to separate steadily. For this late phase, the hazard ratio drops to 0.58. Once the acute risks of surgery fade, the primary driver of stroke returns to atrial fibrillation and the formation of clots in the heart. When we look only at this long-term phase, the risk of stroke is reduced by 42%. This contrast indicates that the appendage is a much more significant factor in long-term cardioembolism than it is in the immediate complications of heart surgery. These data suggest the appendage represents a distinct and modifiable source of long-term risk that persists even in well-managed patients. The clinical adoption of this procedure has faced resistance due to concerns about atrial natriuretic peptide, a hormone produced by the appendage. Some hypothesized that removing it could disrupt fluid balance and increase the risk of heart failure. Returning to the outcomes table, we can evaluate this by looking at hospitalizations for heart failure. The rate was 7.7% in the occlusion group compared to 6.8% in the control. That yields a hazard ratio of 1.13. Since the confidence interval crosses 1, there was no statistical difference between the two groups. Other safety metrics, including major bleeding and 30-day mortality, were also similar across both cohorts. Ultimately, the absence of elevated heart failure or bleeding indicates the procedure is safe from a hemodynamic standpoint. This forest plot shows the effect of the intervention across various demographics. Nearly every subgroup point sits to the left of the midline, favoring the occlusion group. Factors like age, sex, and the specific type of atrial fibrillation did not change the results. The 33% reduction seen in the trial was achieved entirely on top of standard oral anticoagulation. However, because this wasn't a direct head-to-head comparison with medication, these results do not suggest that surgery can replace blood thinners. Instead, this establishes a clear shift in standard care. Using structural and pharmacological tools together provides compounding protection for high-risk patients. By combining a one-time surgical closure with ongoing systemic protection, clinicians can address two different pathways of clot formation simultaneously. LAAOS III provides the evidence that for patients undergoing cardiac surgery, concomitant appendage occlusion offers a permanent way to lower the ceiling on long-term stroke risk. If you enjoyed this video, please give a like and subscribe, and what would be really helpful would be some suggestions for future videos. Today's video was brought to you by Synestec Systems LLC, founded by Shane Persinger.